From theheart.org, Medscape Cardiology. This is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Professor and Chair of Medicine at Stanford University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Stanford University, and I'm here in the Medscape booth on the floor of ACC 22. It's certainly fantastic to be back at a live face-to-face meeting and not having to watch a Zoom screen all day. But we wanted to take the opportunity to chat about some of the really hot topics at ACC 22. I'm really fortunate today to be joined by a colleague, Dr. Jacqueline Themis-Holland, who is a professor of medicine at the Icahn Medical School, Mount Sinai in New York City. And for the purpose of this conversation, Dr. Themis-Holland was the vice chair of the recent ACC-AHA revascularization guidelines that came out at the end of December 2021. Those guidelines have updated a lot of previous statements from the ACC and the AHA, and I thought this would be a good time to catch up on maybe some of the key elements around that. So, Dr. Themis-Holland, thanks for joining me here.
Thank you. I'm so happy to be here.
Well, let's maybe take a couple of things. Let's first talk about process, and for the people who are unfamiliar with guidelines, let's let them know how these guidelines are constructed, and in particular for this one, because you had to bring together different disciplines to address both the surgical issues, the percutaneous issues, the medical issues. And then I have maybe three areas that I want to delve into if we have time. One of which is around the opening section on health equity. The second would be the real change and how long we're recommending DAP. And then what antiplatelet agents we're recommending. And then the third is some of the areas that have maybe made for some controversy around choices of surgical versus percutaneous intervention.
Great.
So let's start first with process.
Yeah, sure. So I think the ACC and the AHA really strive to have a very balanced writing committee. So they need to ensure that greater than 50% of them are not disclosed with industry. They need to ensure that there's a good balance between male, female, and across geographic diversity as well as race and ethnic diversity. The writing committee goes ahead and they are assigned different topics, and each author writes up the section, and then every week we meet to discuss the section and the recommendations that were created, and we sort of meet to agree or disagree and make changes. Ultimately, all of these recommendations are voted on, and everybody has to vote on the recommendations and approve the entire document. With respect to the voting, we ensure that only people without a disclosure can vote. So the voting members are those without disclosures.
So a pretty intensive process in terms of the time commitment, the experts coming together. Talk about the evidence review. What's the process by which new evidence gets reviewed, old evidence gets re-reviewed? How does all that play out?
Right, so we really try to focus on the newer evidence in the last 10 years, but we obviously, for certain situations, you need to bring in the old evidence so you can balance the two. So we generally say 10 years, but the truth of the matter is we really went back in just about everything to many, many years ago, because some of the data, for example, the data on left main disease, really stemmed from trials from 40 years ago without newer data, so we had to take stuff beyond 10 years.
Yeah, and I mean, that's a good example. We're going to talk about the surgical versus percutaneous issues, but that data was great randomized trials for the time, but they're relatively small, and they're not involving contemporary medical therapy. And so part of the question, I imagine, is how do you figure out, how do you balance this notion that now we have really aggressive medical therapy?
Yeah, I mean, that's great, because if you look at the trials, you'll see that there was no antiplatelets then, there were obviously no statins back then, but surgical approaches are much more contemporary now. There's been great advances in surgery as well. So you have to balance the totality of the data we have. Looking at the older trials, which were powered for mortality and outcomes, the newer ones, which are triple, double, triple the number of patients, even quadruple the number of patients enrolled, and really use contemporary strategies for both revascularization as well as for medical therapy. And you have to sort of take it all and balance it all.
Great, and so that's very helpful as background. Let me try to get into my three areas of topics, and then I'll use chair's prerogative to move to another topic if we still have time. But the health equity piece, I think fantastic. I mean, certainly as somebody who has been deeply involved with both organizations, but served as an AHA president, we're very focused on looking at everything we do at the AHA through a health equity lens.
Yeah.
And the document, wow, opens up
Yes.
with health equity.
Yeah. The documents in general, and all of the guideline documents, the new scope is on the patient. So as you can see, it's a patient with coronary artery disease, how do we take care of them? It's no longer a procedural based, how do we do the CABG, how do we do the PCI, but about the patient. So that starts off about the patient. And then it's about the fact that there really is data to show that patients in different races, ethnicities have a worse prognosis, and it's directly related to the fact that they're also having less aggressive care. So we open up the statement saying that there's not really been any trials that show that women respond differently to men overall, maybe in tiny little areas, or that Black patients respond differently to white patients. So the most important thing is about giving the patient the care based on their disease, based on who they are and what they want.
Yeah, I mean, it was really very nicely laid out where it says, just you said, there doesn't seem to be any heterogeneity of effects
Yes.
of these therapies. So let's treat people in a comparable way. But also, as you said, let's make sure we're, to use the phrase, meeting people where they are and bringing in their personal experiences and what they value and what their preferences are. And so I thought that was a powerful part of the document. A corollary to that is the notion of the heart team.
Yes.
And, this started really with the TAVR.
Mm-hmm.
And now it's moved to other areas of medicine, which I think is fantastic.
Right.
So did you have a lot of discussion about that with?
Yeah, I think we felt very strongly, again, in keeping with the idea that it's about the patient, and the scope of the document is bringing these disciplines together to give the patient the best care. We felt the heart team was just directly a subsequent recommendation related to about the patient. So we start with the disparities in care and ensuring there's no disparities in care. We go on to say it's about the patient and shared decision making. And then the third recommendations are about the heart team. So all coming together and saying we should get together. It's not about my procedure or your procedure or medical therapy. It's about what does the patient have, and incorporating their beliefs, their desires, as well as what we know might be more superior. We then go ahead and come to a conclusion for the patient about how best to be treated.
Yeah, and which I think is the way that medicine should be practiced. Yes. And it's interesting. It makes me think of the whole concept of evidence-based medicine, which sometimes gets the rap of, oh, that's just cookbook medicine.
Yes.
Oh, that's just following an algorithm. It's actually not. If you go back and you look at the original writings from David Sackett,
yes.
He says, just as you did, it's the use of the best quantitative information combined with expertise and judgment and put in the context of an individual patient's values and preferences.
Exactly.
And so you can't just take the evidence, you have to put it into context for that particular patient.
In general, there's always an art to being a cardiologist.
Yes.
So you have to be the artist.
So so that's fantastic. Let's move on to maybe some of what I'll call some of the technical issues. Mm-hmm. And one of which is I've done a lot of work over the years in antithrombotic therapy, so I read those sections very carefully. And in this one, you've made a departure from sort of the older perspective of once you're revascularized, particularly with a stent, you get dual antiplatelet therapy for 6, 9, 12 months. Now you're saying that in the stable patient, think about shorter courses of therapy, and also think about what we're starting to see emerge from the literature and from the big trials is switching from dual to single antiplatelet therapy, but here's the other twist, dropping the aspirin.
Yes.
So how did those conversations go?
Yeah, so one thing I do want to make clear, because it's important regarding the process, is that if there are recommendations that haven't changed, we actually refer out to the prior documents. So when we review the data on DAPT, and particularly longer durations of DAPT, we remain with the recommendations in the DAPT guidelines that say it's still a class 1 to say 6 months if stable patients and 12 months in patients with ACS after PCI. However, we added on additional recommendations to say, as an alternative or another way in which you can treat your patient, we want to have you consider that you would use a shorter duration of DAPT followed by P2Y12 monotherapy. And I think we were very comfortable in saying that, because we're not taking away prior guideline recommendations, we're saying adding on to it, this is another option.
Which, the most recent trials, things like Twilight, et cetera, are starting to raise the question of, particularly an era of very contemporary drug-eluting stents, that maybe you don't need that long period of antiplatelet therapy or dual antiplatelet therapy, and maybe you can get rid of aspirin, which looks like it causes more bleeding problems than the ADP inhibitor.
Exactly. Exactly. And the recommendation specifically focuses around the benefits of that strategy is reducing bleeding events.
Right.
Because none of the trials were powered to look at ischemic endpoints. Of course, Twilight showed non-inferiority, and many of them showed, when you look at the pooled data, there's no difference in ischemic events. If anything, a trend toward lower ischemic events. But we really focus on the fact that it's reducing bleeding events.
It's reducing bleeding, and in particular, that group of patients that's been referred to as high bleeding risk, or HBR patients, that taking away one of the antiplatelet therapies earlier probably is a wise thing to do. Exactly. And I see in my own practice that I'm starting to drop the aspirin and continuing my patients on ADP inhibitors, which I suspect a lot of us are going to continue to do. And to me, that was an interesting phenomenon that came out of the triple therapy data, that you can start to drop the aspirin, have just the ADP inhibitor, and you get great results.
Yeah, for sure. And we had a little, well, I don't want to say we had, if you notice in the recommendations, it's 1 to 4 weeks. We're not necessarily saying drop it after the PCI. And I think that's because there is a suggestion that, none of these trials were powered to look at stent thrombosis. And the Augustus data does show that there is a, doubling the stent thrombosis rate when you drop the aspirin, although not statistically significant. And so therefore, when you look at the stent thrombosis rates, they really occur in the first 30 days. So perhaps considering your ischemic risk versus your bleeding risk and deciding on the duration of aspirin, but certainly no more than 4 weeks.
And it gets back to your earlier comment about you take the data and you put into the individual context of that patient. And so you have to look at things like, what was the extent of the, of the anatomy that was intervened upon? Did you have bifurcation disease? Is there long stents? Do they have diabetes? Do they have left main disease? So I think all of this has to enter in. It's not just a one-size-fits-all.
Exactly.
And the guidelines really read that way, which I think is fabulous. The last topic I want to get into is the one that's maybe generated a little bit of controversy. Certainly here in Medscape, there's been a lot written about it, talked about, and that was the choice to downgrade the surgical recommendation for complex multivessel disease from a class 1 to a class 2 and class 2B. And also to say with PCI, a survival benefit is uncertain, very clearly. Now you did a couple of things, one of which is you looked at the older data, you looked at the newer data, and then you even pulled in some data. In full disclosure, I was one of the ischemia executive committee members. You pulled in the ischemia data, which was not a revascularization trial. It was more of a strategy trial.
Exactly.
So how did those discussions go?
Yeah, so it's, it's very difficult to come to the right decision about these sort of things. And as we said before, we're looking at older data that is powered for mortality, but medical therapy arm was very not contemporary medical therapy, and we're looking at newer data, and and I think it's important to recognize it wasn't just the ischemia data, and there's newer data since we published the guidelines on the ischemia and the relative benefit of an invasive strategy in those patients who had really severe disease. So this cohort of patients, and there's no difference in death or in that group, but there is a lower rate of cardiovascular death or MI. In the group of patients who had severe disease. So what we did was, when you look at the pooled data of all of the trials, there's a lower rate of cardiovascular death with revascularization compared to medical therapy, but there's not necessarily a lower rate of lower mortality.
Of total mortality.
And so I think that our biggest problem in the guidelines overall, and even European guidelines do the same thing, is we focus on either symptom relief or mortality. But sometimes it's not about those two things. A patient wants to know whether they're going to have another heart attack or they're going to have another revascularization, et cetera. So when you look at the reduction in cardiovascular events, we see that in patients with multivessel disease, the data suggests that there's a benefit to revascularization to reduce cardiovascular events. So while we downgraded the recommendation for an improvement in mortality because the totality of evidence doesn't support it, we actually provided a new recommendation to say you should consider, or it may be reasonable, to do revascularization with the intent of reducing cardiovascular events in patients with multivessel disease.
Yeah, I'm glad you brought that up, because that specific area has been neglected.
Yes.
That the focus has been on, well, why did this happen to my procedure, or why did this happen to my procedure? But yet what we really said is, look, revascularization should be considered in this group of patients. It does seem to offer benefit, but let's just be careful that we're quantifying and qualifying which benefits it's offering.
Exactly.
And again, pointing out that the guidelines have to be put into the context of that individual patient. Who they are, what their demographic factors are, what their angiographic factors are, and what they care about and what they're trying to achieve. One of the biggest lessons for me from ischemia is that you've got some time to think about these things.
Yes,
And,
that's true.
and that you can really engage in shared decision making around, look, we don't think there's going to be a benefit overall of an aggressive revascularization strategy in many people.
Yeah.
But if you're having a lot of symptoms, well, yeah, it does look like it offers some benefit. Or if you don't want to take all of these medicines, it might offer some symptom relief. So I think it gives us a chance to maybe, to put it bluntly, do a bit more doctoring
Yes.
On the backdrop of data.
Absolutely. There's a great article in New England Journal right around the COVID pandemic of a physician who had a patient with severe ischemia, just like the ischemia trial. And she waited because the patient couldn't get intervention. And she was very comfortable knowing that the patient was going to do well.
Yeah, because the ischemia data had
Yes.
suggested that was the case.
Exactly.
Well, this has been a terrific conversation.
Great.
Thank you for sharing both
Sure.
your time and your expertise. And certainly thank you from an AHA perspective on donating a substantial amount of your professional time to produce such a helpful document. So thank you for listening. This has been Bob Harrington from Stanford and Dr. Jacqueline Tamas-Holland from Mount Sinai talking about the revascularization guidelines. Thanks for listening.